Well, look, there's a lot been happening about BAFF recently. A few publications are coming out. It's obviously going to have a future in immunology, particularly autoimmune disease and its therapy. So I thought it was timely to summarize this whole area, keep it to the basics of what I think physicians and those in internal medicine need to know about. I'm going to start with a patient of mine who's really interesting, a 27-year-old man with a recurrent infection, lifelong history of sinopulmonary infections, pharyngitis, had a tonsillectomy, monthly recurrent bronchitis, 2 episodes of pneumonia. I've listed the other infections here, which include skin infections, chronic diarrhea, maybe tinea, maybe that's not so unusual. He gives a history of having frequent rotating antibiotics, but nothing to suggest autoimmunity or allergy. There's no family history of immunodeficiency, and everything else is working okay. So when you see this history, what tests do you think you should do? What is it pointing towards? Well, the answer is this is a very typical history of antibody deficiency. Indeed, tests confirm that. Examination in these patients, you concentrate on lymph nodes because there's a subgroup of patients with CVID who have lymphoproliferation. Nothing to suggest that here. That same subgroup also has an increased incidence of autoimmune disease. Nothing there either. He was obviously infected at the time that these bloods were taken. Usual serology listed here were pretty well negative. These were done by the respiratory physician. There's a history of having staph in the skin, which is probably relevant. But the important gold was the antibody tests, which confirmed the clinical suspicion of severe hypogammaglobulinemia, with an IgG that was really low. Normal is up above 7, so about less than half of normal. A and M were absolutely missing and undetectable. IgE, not terribly useful in the assessment of immune deficiency unless it's massively elevated, but that's not the case here. EPG confirmed the absence of gamma globulins. Lymphocyte subsets showed sort of a low B cell proportion, but most importantly, the switched memory B cells were very low. Normal, 0.4% and above, so less than 20% of the lower limit of normal. Don't worry about CD21 negative cells, but they're expanded in patients, in some patients with autoimmune manifestations. Not the case here. So the diagnosis was CVID, common variable immunodeficiency, supported by a history of recurrent bacterial infections, marked reduction of immunoglobulins. Of course, you have to exclude other causes, and none were evident here. He was approved for gamma globulin. Antibiotic prophylaxis was continued in the short term. He was to have more detailed studies, including genetic studies in the future, and he did very well on that. His infection rate was markedly reduced. He had a few ongoing gastrointestinal problems, as many normal people do, I guess, and many patients with CVID have that complication of CVID enteropathy. He went off to have an endoscopy, but that didn't confirm that suspicion. So sort of an irritable bowel type presentation. Patients with immunodeficiency are not obviously exclusive of other associated other common diseases or conditions. But the interesting thing about it was that we enrolled him in a genetic study that I was doing at the time, and the BAFF receptor sequencing showed 3 mutations. And to cut a long story, interesting story short, his parents had a similar mutation, 1 on one chromosome and 2 on the other chromosome, and he had inherited all 3 mutations, making him a compound heterozygous for BAFF receptor deficiency. This is the flow cytometry profile of BAFF receptor expression. And you don't need to really understand this except to say that his expression was much reduced compared to normal, and his heterozygous parents had about 50% of expression. So it wasn't absent expression, but it was certainly very low and consistent with a significant abnormality. Now, you'd have to do some functional studies to prove that these mutations were pathogenic, and I don't have those results for you. Anyway, to summarise this case, this is a 27-year-old man with CVID due to this very rare deficiency of BAFF receptor. Now, you'll remember from my teaching materials that over here, a rare explanation for CVID is BAFF receptor. But of course, you're not going to have to remember that. This is just an illustrative case of CVID where a genetic explanation was found, which occurs in about 1/3 of patients. This deficiency, autosomal recessive, there are patients with defects who are completely normal, so low penetrance, variable expressivity, probably other explanations or other genetic defects that might contribute to its clinical expression. Okay, so that is a bit of a clinical prelude to BAFF, one of the reasons why I'm interested in it. So what does BAFF do? Well, we talk about that in my lectures. It basically promotes B-cell maturation. So BAFF, a transitional B-cell, one that's just emerged from the bone marrow, expresses BAFF receptor, and that is acted on by soluble BAFF, and that mediates the transition from a transitional newly emerged B-cell to a fully mature B-cell, now co-expressing IgD along with IgM. And it continues to express BAFF receptor until it differentiates into an antibody-forming cell. So this stage between transition and mature correlates with the migration to the secondary lymphoid tissue and competition for access to the established B-cell recirculating follicles. A lot of B-cells don't survive that transition, but BAFF is one of the factors which are important in making it. This is BAFF is a cytokine in serum mediating that transition. It's also in those B-cell follicles to enable those B-cells to survive. And if you can't receive BAFF, you don't make that transition, and your B-cell compartment is somewhat compromised. Of course, the patient in question obviously didn't have that impairment, which is why I say that there's likely to be other factors involved in his clinical expression. Now, of course, the BAFF system is not just as easy as BAFF acting on BAFF receptor. It's complex, and we talk all about it in the lecture and the chapter of the relevant book. There is another similar member of this BAFF family called APRIL, and that combined, and BAFF combined to BAFF as well as the receptors for APRIL, which include TACI and BCMA, and APRIL just binds to TACI, BCMA, but not BAFF receptor. Now, these all have therapeutic implications, as we'll come to shortly, and BCMA is an important expression protein for plasma cells and also a target for therapy for myeloma for that reason. But we're not going to concentrate on APRIL and that system for the moment. We're going to stick to BAFF because that's just enough for one day. So having established that biology, how can we then use that knowledge to advance treatment for immunological disease? Well, the first kid off the block was Belimumab, which is a fully human antibody which blocks soluble BAFF and prevents it interacting with the BAFF receptor and paralyzes B cells at this sort of transitional stage. It does work in lupus and lupus nephritis. It's not a game changer. It works a little bit. It doesn't have spectacular results, but it is proof in principle that inhibiting BAFF may be one of the pathways that could be useful in future treatments for this condition. And that is support. Oh, this is the evidence of that activity. You'll see that when you add Belimumab to the usual lupus treatment from patients with mild to moderate disease, there's reduced activity, decreased number of severe flares, decreased steroid use, improved energy, and therefore it's not unreasonable to add it on to the treatment of patients where control is suboptimal. And this shows you the response rate depending on the dose. It was then trialed in renal lupus, and it did improve outcomes marginally. So you'll see an improvement, and that improvement was sustained up to 2 years. But it's not like the rate goes up like enormously. It does something, and that led to its being approved. In fact, the first drug since Plaquenil to do so. So it did hit the news from that point of view, but it hasn't set the world on fire. It's available. It's not funded in Australia, at least, but it is there and does tell us something about the biology that's going on in lupus. Other things are coming out, and I've pointed these out to you previously. In this system, there's a drug called TACI-Ig, which is just the TACI, the other receptor for BAFF that I mentioned, tagged to the Fc end of immunoglobulin, and basically that acts to inhibit BAFF, but it will also act to inhibit APRIL. And the results in lupus are looking promising, and I've already spoken on this forum a few times, perhaps on the Patreon site, about its use in IgA nephropathy. Some of the drugs were limited by infection side effects, but you can manage the dose around that in order to gain therapy without the cost of infection. And there's another drug developed in China, telitacicept, and that's looking pretty good for lupus and IgA nephropathy. And the latest kit off the block is ianalumab. I put that in brackets to know that it's not lanalumab, ianalumab. And there's been a few publications on this recently. So ianalumab is a fully human monoclonal against the BAFF receptor. So belimumab was against BAFF. This one's against the BAFF receptor. And so that works in two ways then. It's not just affecting this transition between transitional B cells and mature B cells, but it will also kill anything that's expressing the BAFF receptor in the way that belimumab won't. So this actually leads to B cell depletion via this process of ADCC, antibody-dependent cell-mediated cytotoxicity, to kill that target cell. And as you know, B cells are generated continuously throughout life. So once you kill a B cell, more B cells will be made to fill the gap. Well, this drug will also act on those to inhibit that maturation process. So dual mode of action, does it work? Well, this is the most recent article that I came across late last year, where it has a role in ITP. So these are supportive phase 2 studies. There are very good studies in Sjogren's. Sjogren's is a hard disease to study because it's so slow and it's hard to measure outcomes. But there was a mild to moderate reduction in disease activity and improved symptoms. So that's sort of looking good for Sjogren's. Emerging studies in ITP and lupus, and probably other autoimmune diseases. Watch this space. Looks pretty good in terms of tolerability, and it made it on the FDA as a breakthrough therapy for Sjogren's. But watch this space, it may fill a void. All right, so that's most of what I wanted to say about BAFF. So let's just pull that together. I think you should remember that BAFF is a key survival cytokine in that transitional to mature B cell stage of B cell maturation, acting via the BAFF receptor. I've given you a case of BAFF receptor deficiency, probably explaining the patient's CVID phenotype, but I wouldn't remember that because it's so incredibly rare. There's only going to be a handful of cases worldwide. So just something that's interesting that maybe you don't need to keep in your brain. More importantly are the therapeutics and the emerging therapeutics. So as these papers come out, you can then refer back to this talk so that you can remind yourself of why they are effective. So we've spoken about Belimumab, an anti-BAFF monoclonal of some benefit in lupus and lupus nephritis, and we have these emerging treatments of TACI-Ig blocking both BAFF and APRIL, which are looking good for lupus and IgA nephropathy. And the latest one, ianalumab, good studies showing benefit in Sjogren's and emerging studies showing benefit in lupus and ITP. So what do internists need to know? You need to know about this BAFF axis and the importance in B-cell maturation. Be aware of the therapeutics which are available targeting that pathway and its likely and the likely future role of these agents in treatment of autoimmune disease, of which lupus, Sjogren's, and ITP and IgA nephropathy to some extent are the ones which are worth watching and looking front runners at this stage. When I say IgA nephropathy, of course, that seems to be mediated mostly by APRIL rather than BAFF. So a pure BAFF blocker may not affect that, but a dual BAFF and APRIL blocker seems to be the way to go in that condition. All right, I will leave it at that. Just to remind you of all the resources that I coordinate in clinical immunobiology, both the lecture series, my publication, which match each other very closely, this YouTube channel, my question of the day on Instagram, and the community of learning over on the Patreon site. So I hope those things are all useful to you. I will be back with another lecture in the near future.